All right. Good afternoon, everyone. Thank you so much for joining us to another NASCI Curious Cases webinar. This is our 13th webinar. So I guess this is Diana. This is the bar mitzvah, a year of the webinar
Yes.
or something like that.
Yes.
13 months of webinars sharing some really cool cases with friends, which I guess is one of the most exciting things to do, to be able to share with our friends. Thank you everyone for joining. We have some people on the call. I'm sure more people will be trickling in, and I know Dr. Limanovich has some cases that she's going to share with us. I'm going to make her the presenter. I'm going to ask you to accept to share your screen. You hit yes, and you can take it away. And again, guys, remember, if everybody's welcome to participate, show cases, ask questions, but if you're not talking, just keep your computer or phone on mute so we don't get background noise.
Okay, do you see my screen, guys, or not yet?
Not yet.
Okay, let me try one more time.
Did you hit accept when
Cheers.
Yeah.
Okay, how about now?
We do. Perfect.
Okay, wonderful. And I am glad that there are trainees on the call, because this is really a case for from everyday life, and that is possible to see, either during your regular rotation or your ED rotation. But let me start showing you this case where we see two chest radiographs that were taken, as you can see, 6 hours apart. Now, this gentleman, who was in his late 60s, has presented with chest pain and shortness of breath that went to an extent that his shortness of breath went to an extent that he was intubated. So what you see here is a nice depiction of two chest radiographs where you can see vascular engorgement and some mild interstitial edema on the first case, and a very rapid, within 6 hours, progression to a very florid pulmonary edema with both alveolar and interstitial component and curly V lines. And we can talk about, and we can make a 1 hour session just talking about the curly V lines and pulmonary edema in this case. But there is a reason why I'm showing it. So if we look at the next image, this patient, in between those two scans, shortly before the second x-rays, in between those two x-rays, shortly before the second x-ray, underwent a CT. And what was the question? Guess what the question was? Patient arriving to the emergency room with shortness of breath. What is the indication for a CTA of the chest?
PE.
Exactly. The question was pulmonary edema. The fact that he had, sorry, the question was pulmonary embolism. The fact that he had pulmonary edema, okay, sure, but let's exclude pulmonary embolism. So we did this case, and as you can guess, there was no pulmonary embolism, but what we did see is a very unusual appearance of his left ventricular myocardium. And again, primarily for the trainees on the call, you can clearly see that the more posterior aspect of the septum and of the lateral wall have normal enhancement, as opposite to the septum and anterior septum and anterior left ventricular wall, that on multiple projections you can see various degrees of hypoenhancement. So this is a hypoenhanced myocardium that we see on a regular non-ECG gated CT scan that was done with IV contrast. You can also see that although some of the areas of the myocardium have normal thickening, the anterior aspect of the myocardium is not demonstrating a normal myocardial thickness. So this patient was taken to the echo, and let's see if that would play. But if it doesn't play, and it doesn't, you will have to believe me that it was an extensive hypokinesis of the anterior wall and the lateral wall of the left ventricle. So the question here that I would ask the trainees to pick, what is your diagnosis in this case? Anybody? Anyway, I don't see or hear who is talking. So you can just say 1, 2, 3, or 4. No takers?
I guess
Okay,
it is 2.
1.
okay, I hear 1. Any other takers?
2.
2. Any other takers? And I must say that the 2 voices that I hear came from females. So go girls. Okay, so I just want to tell you, as a companion case, a different case of a chronic myocardial hypoperfusion due to CID, where you can see hypodensities, very low in subendocardial areas, and you can even see it on a non-contrast enhanced study where you see the hypodensity outlining the endocardium. Okay, again in the territory of a particular coronary artery. So this is a case where we can see the chronic myocardial perfusion. Just as this is a different case as a complementary case. Okay. Now going back to our case, I'm giving you a little bit more details on it. So this is how the LAD of this patient looked like. And this patient was taken to cath. And what it showed, as you can see, is that the previously placed stent demonstrates what? Normal appearance of the stent, occluded stent, stenose stent. What do you think?
Occlusion?
Occlusion.
Absolutely. So basically, in a way, the answers that the answers that you have given were both right in a way. It was an acute process. There was an acute occlusion of the previously placed stent. So this patient did have a chronic coronary artery disease, but the whole constellation of events that we have seen and the imaging findings that we have seen were due to acute occlusion. Okay? Any questions about this case?
So the thinning of the myocardium is actually related to underlying chronic coronary artery disease, right?
Yes.
Okay.
Yes. But what we saw in this case, the hypoperfusion of the myocardium, when we see it in this way, when it involves the myocardium, and you can see normal myocardium, and then let me go back to this image. So this appearance of hypoperfused myocardium that still has a normal thickening, normal thickness, not thin, this appearance, when you see it with the diffuse involvement and very sharp demarcation, and again normal preservation of the thickness of the myocardium, is typical for acute or sometimes subacute process, but it's not consistent with a chronic disease. The chronic appearance of the scar is what you can see in this image, where you see subendocardial hypodensity, usually associated thinning of the myocardium, and you can see it again on both contrast enhanced and non-contrast enhanced studies, as opposite to acute hypoperfusion, where on non-contrast enhanced study you will not see any findings, most likely.
Diana,
Yes.
that's a great case. And
Thank
one
you.
of the first images you showed was this perfusion defect. Would it be okay if I show a companion image?
Perfect.
Okay. Jacobo, can you wave your wand?
I'm sorry?
Jacobo, can you make Greg now a presenter?
No. Let me see. GK, make present.
Because he has a companion case, would make sense to do that.
Okay, so it says this is okay. Just a second. Okay, just a moment. It's asking me to give it permission. Okay. Now it wants me to restart GoToMeeting. Okay, I'll come back in 1 second. Okay.
All right. So, Diana, you want to keep presenting in the meantime, I guess? You want me to share with you?
Sure. Do you still see my screen?
No, I need to find him.
Okay, I'm back.
Oh, there he is. Okay.
Oh, he's back. So let's
Okay.
continue with Greg's case.
Do you need me to ask you to share the screen again, Greg? Probably do.
Okay.
Um,
All right. So I just want to show this one image, Diana, because I've seen this happen many times where people they keep their eyes open for this perfusion defect. But what I have seen many times is that because in scanners that are doing step and shoot, there's a difference in contrast enhancement as you move through the heart in different slabs. If you don't have a 256 scanner, if you have the 64, and usually on the first rotation there isn't as good enhancement, and so the anterior wall, the LV, can sometimes look like it's poorly enhanced compared to the rest of the myocardium. And as people look at those images, they think they're seeing an anterior wall perfusion defect. So this is an example of one, and you can see there's low signal intensity there. I don't know if you can see my mouse. And sometimes this is not the world's best case, but sometimes it's quite dramatic where that anterior wall just looks very under perfused. And if people aren't thinking about it right, they don't notice the line from essentially like a stair step artifact, and they'll call a perfusion defect on the anterior wall.
That's a great case, but you know what? As my grandma used to say, those are the problems of the reach. So the case I have shown was done on a simple 64 slide scanner. That artifact would not have been even possible. But it's a great reminder for us to think about it when we have the acquisition, which would be potentially too fast. That's essentially what you're saying. We are outrunning the contrast.
Well, no, it's that the first rotation of the gantry that catches the anterior wall, there isn't a lot of perfusion, like the contrast bolus hasn't hit its peak. And so then on the next rotation, the rest of the myocardium looks brighter. And so people see this on the axial, they call it perfusion defect, but when you go to the coronal or sagittal, it's obvious. It's just timing of the bolus going in. So that's not your case. I'm just saying I've seen so many people. This is a problem we have here in Seattle, but I know in Boston they're a little sharper, so they probably don't fall prey to that.
No.
May I show a quick companion also?
Yep.
Sure.
Yeah. Jacobo, if you can just share with caller 01.
Hello?
Caller 01. I don't see.
Or no, it's probably, well, it's me, Phil Young. I think.
No, I know. So,
I've called in separately. Yeah.
so I have a Y. Is that you? Yeah. Okay. Make presenter.
Yeah. So this is just another example here. What we tell our trainees is our pack system makes it easy to just thicken the slices. And so if you make an average intensity projection that's like 7, 8, 9 millimeters, and then if you put it on a color map, often these perfusion defects really just jump out, right? Like you see this here. This was a dissection CT where it's fairly subtle on the actual CTA images. On a sharper window, it's more conspicuous. But if you go into standard cardiac imaging planes, thicken the slices, and then put it on a color display instead of a grayscale, it just jumps out at you. This is somebody who had an OM stenosis here, and it's another argument for retrospective gating, right? Is that if you can go and look and say, not only does that persist throughout all phases of the cardiac cycle, that really raises your confidence, and you can look for wall motion abnormalities, which frequently are present in the acute setting. So that's my 2 cents.
And what software do you use for that? Maybe you just said that and I overheard it.
We just do, our PAC system is Visage, which makes it very easy. You can do it in Terra Recon too, but.
Correct.
I see. Okay.
I'm not gonna show. I have a companion case as well. I'm not gonna show it just because I mean you've seen a couple already, but it's on my Twitter feed if you want to see it. And it was very interesting to see the cardiologist. The patient came into the ER with chest pain. They, for some reason, they were exclusively thinking of dissection, and I know Phil can go on about the triple rule out now, but they just did a chest CTA without gating for some reason. They didn't want without contrast. I'm not sure why. If for intramural hematoma, you would like to have that, but they did that. And on my report, I basically said there's hypoperfusion LAD distribution, which concerning for an infarct or ischemia, and there was a lot of calcification in the LAD. And lo and behold, they took the patient to the cath lab, had a very tight stenosis of the proximal LAD, and within 10 minutes, the cardiologist was in my office like, how do you see that? What are you looking at? I've never seen somebody talk about this coronary distributions on a chest CT. And I'm like, actually, so I went over it, and it was, we did a good thing for the patient there. So it's, I guess, for the trainees, always look at the perfusion of the myocardium in these patients. The rule out PEs, the rule out dissections, anybody with chest pain coming to the ER, is very important to look at this because we do catch these patients.
I mean, the reality is patients are about equal, if they're lower intermediate risk chest pain patients and they get a CT for PE or dissection, they're about equally likely to be having a heart attack. Is the thing we're actually looking for statistically.
Correct. All right, Diana, I made you presenter again, so you can continue with
Okay, let me go back. Share. Now, let me make it. Let me make it 1. Okay. Just 1 second when it's loading. And okay, do you guys see my slide? Do you guys see it?
Yeah, we see it.
Okay. Okay, great. So this is another case with pretty much kind of a finding that we can see day to day, and also of value for our trainees. So this is a patient, 42 years old, a woman with exertional chest pain. She came and she was, we're talking about modern history. So the first study that she underwent was a coronary CTA. And I'm showing you these 3 images from her coronary CTA. And I'm going to show you now also reconstructions that were done from her coronary CTA. So curved reconstructions and a 3D reconstruction. Okay, so I'm going back to axial images, and you can right away see an abnormal vascular structure that goes anterior to her pulmonary artery, that goes eventually into the location of the LAD. You can see similar structure, same structure that is coming from the right coronary artery and goes again anterior to the pulmonary artery. And this is the same vessel that you can see on the 3D volume rendering reconstruction. Okay, this is just some annotations on the same images. And then my question is, would you select 1, 2, 3, or 4 from the differential diagnosis that I'm showing you?
3.
Please don't be shy.
3.
Okay, one was selecting 3. Any other takers?
Agree, 3.
3. Anybody else?
3.
3. Anybody else? Okay, 3 for 3. And indeed, that's what it is. This is a typical case when we are talking about a prepulmonic cause of the LAD. Okay, so in this particular case, you see the vessel. You can also see several areas of narrowing caused by the coronary artery disease in this vessel. Okay, and this is a 3D volume rendering, just a different view to show you the course from the right coronary artery as it goes anteriorly in the prepulmonic location, as the name states it. Okay, This is a different patient. Now, tell me what is different about this patient. Can somebody want to take a chance and tell me what is different in this patient compared to the other patient that we saw? We are again looking at the anomalous origin of the prepulmonic vessel coming from the right coronary artery. But what is different here? So in this case, all the three coronary arteries coming off the right coronary artery ostium. Do you see that? 1, 2, and 3. And in the previous case, we only had the LAD, and the circumflex was originating from the regular location. So this is just a different patient with similar but yet slightly different constellation, where the right coronary cusp gives all gives the origin to all the three vessels. Okay, now the prepulmonic cause of the LAD can occasionally be mistaken for the conal branch, okay, because we will see in another vessel that is going to be going anterior. The conal branch is usually much shorter, and the importance of the conal branch is that it might serve as a collateral with the LAD, like in this case, where we can see the arch, which is created between the conal branch and the mid-LAD, which would be distal to the severe narrowing, distal to the stent in the LAD. So do you guys see the name of this arch? I don't know if it's projecting on your screen. Do you see it?
We don't see it. So
So
sort of just the one top of the letter V.
yeah, so it's called Vucens artery, and I'm sure I'm not pronouncing it right. It's a German last name. But if you see something in this constellation at the boards or elsewhere, this is the name of this particular collateral between the conal branch and the LAD, which is created to supply the right to left coronary artery supply. So this is the importance of us recognizing the conal branch and just knowing about this potential collateral. And then the conal branch can sometimes be mistaken for the prepulmonic course of the LAD. Any companion cases on the coronary anomalies that we can look at now? Jacoba, I can show one more case, or we can switch to somebody else presenting.
Let's see. So I think you can show, because I can always save whatever I have for the next time. But does anybody else have a case that they want to show? That they prepared?
Go ahead, Deanna. I have some too, but I can save them for next time.
Sure. All right.
Okay. Let me show one more case. We are again in coronary arteries. So this is a 57-year-old man with acute chest pain and family history of coronary artery disease. So what we see here is the axial images of the coronary CTA, and we can see a small amount of pericardial effusion, but we also can see a large round lesion that surrounds proximal right coronary artery, and we can also see a dilatation of the right coronary artery within this large lesion, and we can also see some contrast that is outside of the lumen of the right coronary artery. This is the LAD of the same patient, just showing a mild to moderate stenosis in the proximal mid-LAD, just to show that this patient has a coronary artery disease. Okay, we can also see that there is a severe ostial stenosis of the right coronary artery and the dilatation, and again, as we said, a filling defect in the proximal vessel. And the stenosis of the proximal LAD. Okay, this is how the right coronary artery looks at this 3D volume rendering. We can see the narrowing of the proximal right coronary artery. We can see the dilatation, proximal dilatation of the right coronary artery, and we know that it has that it's partially occluded. Okay, so now pick a number. 1, 2, 3, 4, 5. Any takers? Any numbers?
Pseudoaneurysm.
Okay, so that would be a number 4.
Yep.
Okay, so we have a taker for number 4. Any other takers?
One.
A taker for number 1. Any other takers? Okay, let's see. So this is an atherosclerotic aneurysm, number 1. Now let's try and see why. So coronary aneurysm complication, why do we do that? We want to see the thrombus, we want to prevent the distal embolization, and the discovery is usually incidental. Now, this is a case for the saphenous vein bypass graft aneurysm. Now, as we know, they usually can be seen around the cardiac contour above the left ventricle if it's involving the bypass to the left coronary system. And we usually see them when they're large and they're filled with thrombus. Sometimes they do and sometimes they don't have calcifications. And that definitely could be something that we might mistake for a native coronary artery aneurysm. We need to see where the bypass is located. We need to see, we need to know the story of the patient. This patient that I have shown you did not have any CABG in the past. Now, this is a different patient with a different aneurysm, which is due to Kawasaki disease. And you can see here that it also looks very different because it's usually multiple areas of aneurysm. Some areas are ectatic, some areas are truly aneurysmatic, as you can see in this case. So this, and if we're talking about the young patients in Kawasaki, we don't usually see any evidence of calcifications or atherosclerotic plaque. Okay, and this is the same patient just in 3D. And in this particular patient, the coronary arteries were so big in Kawasaki that they were able to see it on echo. Now, the point is that with the coronary, with the native coronary artery aneurysms that are due to atherosclerotic disease, what we usually see, we see that they are more common in the right coronary system, which would be in favor in our patient. And also when we see them, we usually see severe atherosclerotic disease in the other vessels, like we saw in our patient. And that's what makes us to suspect coronary artery due to atherosclerosis. Now, pseudoaneurysm, it's a good thought, but for pseudoaneurysm, we usually would need to have a history that would predispose to that, either previous intervention or trauma, or maybe a severe endocarditis, some suspicion for an infectious disease that would cause it. But if there is no history whatsoever, the patient presents de novo, especially if it's the right coronary artery involved, and we see atherosclerotic disease elsewhere, we should suspect coronary artery aneurysm. Okay, and that were the cases that I wanted to present today.
It's pretty awesome. Thank you so much, Anna. Those were really great and great discussion.
My pleasure.
Everyone. All right, Dr. Denny, you want to show a couple and then I'll show a couple? Or we play it by ear?
Just let me reopen my presentation if I can find it. Okay, I'm using a different computer and it's, are you, okay, it's just asking me again.
All right, let me ask you again.
It's, yeah, I just have to put in my administrator and password to be able to share.
Oh, it says that you're the presenter already.
Privacy issue again.
Okay. I see you. I guess that's you logging in. We'll just give it a second.
Yeah.
Let's. Did
Okay, do you want to try sharing again? I have to restart GoToMeeting.
Okay. There you go. That should work.
Okay. So you can see my screen?
Not yet.
Not yet. Okay, do you want to try sharing again? Or giving me control?
It says that you're the presenter.
Okay.
Did it ask you if you wanted to present, to accept?
No, it didn't.
All right.
Not after I rejoined.
Okay, let's see. I'm sending it to you again. There you go. Did it?
Okay, now it did.
Okay, perfect. There you go. Now we see your screen.
Okay, so mine are more show and tell than quiz cases. So first case is a 21-year-old man with an abnormal chest X-ray. So, so he's 21. So I think, does anyone want to volunteer to describe what they see? I think if you concentrate on the mediastinum, if someone wants to describe the abnormality, otherwise I'll just go ahead.
The ascending aorta is possibly dilated or enlarged.
Yeah, exactly. So certainly for a 21-year-old and even for pretty much anyone, you can see the outline of the right side of the mediastinum is it goes too far to the right, and then there's filling in of the retrosternal airspace on the lateral view.
He looks tall.
Pardon me?
I was going to say he looks tall.
Yeah, but that's a good point because there are many causes of dilated ascending aorta in a young male, and this is his MRA, and I think it was 4.9 centimeters. So certainly you'd want to consider any kind of congenital connective tissue anomalies like Marfan's, or less likely Loeys-Dietz or other inherited aortic diseases. But in this particular case, we also looked at the aortic valve. And so this aortic valve is abnormal. Does anyone have an idea what's wrong with that aortic valve?
It is bicuspid aortic valve.
Well, it certainly looks like it only has 2 cusps, but when you have a bicuspid valve, which would be in this case like a completely, like no a type 0, right? Because there's just 2 cusps with no visible raphe. But here you can see that
it's functionally
the opening goes all the way to the edge of the aorta on the posterior aspect, but on the front it doesn't quite touch.
Okay.
So this is a really rare type of aortic valve.
Is it
and it's
one lower than bicuspid?
yeah yeah, exactly. It's a unicuspid valve, And, it can be variable to a tiny little pinhole or, a bigger opening that almost goes to the edge. And there's also aortic stenosis in this patient. So these patients can usually present quite a bit earlier than those with a bicuspid valve, and have to have surgery. So he had ascending aorta and aortic valve replacement at the age of 21. So quite a rare type of aortic valve. I just have another case, and a 23-year-old with also has a dilated ascending aorta and almost an identical appearing unicuspid valve. So again, just at the very anterior aspect of the valve, that it doesn't quite reach the edge of the aorta. So another unicuspid valve that was treated surgically. So these are two proven cases of unicuspid valves in young men. It's more common in men. And then I think next image is an example of what this would look like at pathology. So,
Carol, I have a companion image if Jacobo wants to just share over to my screen.
cool. All right.
You got it? There you go.
Yep. So this is a quadricuspid valve, and you can see there are 4 discrete cusps there, and there are also pentacuspid valves, of which I don't have a case. So if anybody has the pentacuspid, it's been published. That means we've got 1, 2, 3, 4, and 5, and so that would be
That'd be cool.
yes. So anyway, yeah, just a case of pentacuspid valve. I mean, sorry, this one's quadricuspid. Okay, that's all. You can send it back to Carol, Jacobo.
All right, let me find the right Carol because I have like a bunch of them here from that. From the switching to the admin. That should be the right one. Let's see.
Yeah, I think so.
Perfect.
Okay. See, I can't remember what my second case is. Okay, so 70-year-old woman with hemoptysis. So here, pretty classic case of a lung cancer with subcarinal right hilar lymph node metastases and some pleural metastases. You can see in the major fissure and then along the lateral pleura here, posterolaterally in the pleura. But she also had something else in the right atrium. Sorry, my slides didn't get moved properly, so they're still sitting unmoved. But you can see this lesion in the right atrium. It's got some calcification in it, and we did some 5-minute and 8-minute images. So she did have a cardiac CT after the fact. And I was just putting these slides together actually when Deanna was speaking. So I don't think my next slide made it over. Yeah. So the lung cancer itself and then the subcarinal nodes were quite avidly enhancing on the late iodine enhancement CT. So the differential diagnosis here, I'm going to say 3 things. And so number 1, is this a metastatic deposit? Number 2, is this a thrombus? And then number 3, is this just an incidental right atrial myxoma? So what do you guys think? Number 1, 2, or 3? Met, thrombus, or myxoma? No takers?
Thrombus.
I think we
Do you have
included, sorry? We don't have path proof, and it's possible actually, Jacobo, that this is indeed thrombus, but it was very round. And so we favored it to be a right atrial myxoma. But I think without pathological proof, I guess we couldn't really say whether this is a thrombus with some calcification within it versus a myxoma. So atrial myxomas, you know, about 85% of them, or close to 85% of them, are in the left atrium, but about 15% of them occur in the right atrium, and then they can also occur in the other cardiac chambers, much less commonly. So the second most common location is the right atrium. So this lady went for chemotherapy of her lung cancer, and then this has just been left in place because of her age and the advanced lung cancer that she has. Any questions? So the next patient, also a show and tell here, 19-year-old with a parietal stroke. And this is a chest CT on the top left, and then he had a cardiac CT following that. And so here we see a filling defect in the right inferior pulmonary vein. And he subsequently underwent cardiac MR. I just want to show you his chest CT as well. The unenhanced CT shows calcified lymph nodes in the subcarinal area and both hyla, and he has innumerable lung nodules. They're all small. They're many of them are calcified. So this is his MR, so kind of a coronal oblique of the inferior or the pulmonary veins and the coming into the left atrium, and so you can see that filling defect. And I think I have T1, T2, and then post-GAD. So it's pretty dark, and then it's kind of iso-intense on T1 and almost iso-intense on T2, but then very dark on the late GAD images. Just a few more of the late GAD images here. And so the differential here, it was behaving like a thrombus, but because of the worry, first of all, for more embolization, and that I personally had never seen a thrombus and still haven't in the inferior pulmonary vein since that time. I thought, well, could it be a primary malignancy that's just not enhancing, that has mostly thrombus attached to it? I've never seen an infection or like it wasn't attached to a valve. So I couldn't really think of anything else. Can anyone postulate anything related also to what's going on in the lungs? Like, it looks to me like histoplasmosis. But in the end, this patient went to surgery and it ended up being bland thrombus. Has anyone ever seen that in that location?
No,
No, no, in the absence
only
of,
sarcoma.
exactly.
I thought for sure it was going to be some sort of low-grade sarcoma with a lot of thrombus on it, but it was just bland thrombus. And
he's still, this was a while ago, so it was probably 7 or 8 years ago, and he's still perfectly fine. So very, very unusual. Jacobo, do you want to show? I have some more, but I can wait till next time.
Sure, we have a few more minutes. I'll just show a case or two, and then save also the other ones for next time. Thanks, Carol. Let's see. Let me know. I think you guys can see my screen now.
Yep.
All right, let's see which one I can show. So this is going to be a quick show and tell. 48-year-old female. She has a history of B-cell. There you go. And she was on remission, but presented with significant shortness of breath. So they sent her for a CT of the chest, P protocol. You can see the pulmonary arteries are enhancing quite a bit. That's where the bolus was aimed for. But I mean, there's something not right, and I don't think it's subtle. Any comments? Any guesses? So the patient, again, patient with a history of B-cell lymphoma. So while she was on remission, there was mutation of the cell line for the lymphoma, which recurred, and now she's got cardiac lymphoma, which is pretty diffuse. You can see all those nodular masses. It does have that soft lymphoma-like appearance, where it's not really displacing or putting mass effect on structures, but just kind of like nodularity that it kind of involves and invades and extends around the structures, and it goes into the chambers and outside. So it's all cardiac lymphoma. Um, of course, it's not primary cardiac, which is it's rare to see those disease in a patient with known lymphoma in the past. And talking to the oncologist, we've had we see this time to time. These are really hard to treat, mainly because lymphoma usually responds pretty well to therapy. But the problem is when you have all of this infiltration of the lymphoma in the cardiac walls, and it reduces the lymphoma burden very quickly. You can really thin out the wall. You can make holes in the wall, and the patients can exsanguinate and go into tamponade. So when you have myocardial wall involvement, they usually go a little bit slower on the chemo. They're more careful to try to get rid of the lymphoma, because there is such a thing as a chance of creating a hole in there and giving the tamponade, which I never seen it happen, but that's what the oncologist told me. I don't know if you guys have heard similar stories or not.
Yeah, I've heard the same.
So that's the one quick case. I'm going to show this case. So you can see here, this is a 41-year-old guy. So this is a patient from an outside institution. We just started reading some of the cardiac MRs for them. So they kind of give us a bit of a history. We protocol it, and they do the scans, 200 miles away, and start sending us the images as they go, and we try to supervise. This is a 41-year-old male. The history is his brother. So let's say he's a few years older or younger, who knows, has a history of hypertrophic obstructive cardiomyopathy with significant scar burden and an ACD in place. And this patient presented with ventricular tachycardia and PVCs. So the cardiologist immediately, wanted to make sure that what was going on. The echo was not great quality for some reason, and there were some questions about the thickness of the myocardium. But he wanted an MR also to look at scar burden. So just quickly, this is some axials, and you can see the myocardium. Even though the images aren't the greatest you've seen, you can see that the myocardium doesn't look particularly thickened on these images, which appear to be end-diastolic. when you look at the 3-chamber or long axis images there, hopefully the video, I don't know if it's projecting too well or kind of choppy. There's no real obstructive pathophysiology. There's some mild thickening towards the base or maybe near the LVOT, but there's no SAM and there's no turbulent artifact related to the high velocities from turbulence at the LVOT. And please, if somebody disagrees with me, this is an unknown case. I wanted to show it to get opinions from the group. Let's look at the short axis here. There you go. So again, not particularly thickened. And again, maybe a little bit towards the septum there at the base, but I'm not really impressed. It measured somewhere between just over 10 millimeters, I believe, if I remember correctly. So there's a lot of images here. Let's see if this will load. They are sorted differently, so I'll tell you there's a little bit of thinning here at the anteroseptum of the base where my cursor is, if you can see it, and it's not moving as well as the rest of the heart, but again, it's very focal. The EF was normal in this patient. So if we look at some of the late enhancement images, I think you can see here, there's this subepicardial enhancement here at the anteroseptum at that area of thinning, but also here at the infraseptal and just inferior wall, which is a little bit more interesting because that definitely is not an area where we see commonly in HOCM, and it's very epicardial, if anything. So you can see there it becomes almost completely inferior wall segment there in this patient. And there's a good 2-chamber. Let's see, short axis, long axis. Let's see if this one is. And you can see it here. This patchy late enhancement inferior wall, very epicardial in nature. So what I said about this case really was I started to think maybe this hypertrophic cardiomyopathy of the brother is a red herring. Is just kind of throwing me off. It really looks like either myocarditis or sarcoid, and the clinical presentation is really in line with sarcoid. So that's what I called it. I recommended a PET to further characterize the possibility of sarcoid on top of all the clinical information as well. And going back to the axials, unfortunately, well, fortunately for the patient, I guess, I don't see frank findings of pulmonary sarcoid. Sometimes you see that nodularity, you can see the adenopathy. There really is none of that in this patient. So that's what I think this is going to turn out to be. Any comments, any suggestions from the group? Anybody wants to add something?
I would have said the same thing, Jacobo.
Good. And I think the cardiologist was satisfied with that recommendation, and I do think we're gonna get the PET. So
I was wondering if there was mid-wall enhancement in the septum at the base. Can you scroll through that one more time? The short axis.
Of course, just for you.
Because I was really focused on the hinge point, and I think there may be mid-wall at the base. So perhaps it's an advanced HOCM that it's starting to get not as thick.
Yeah,
you know what I mean?
Yeah.
I would put that one first and sarcoid second, but who knows?
I agree. So
EF normal or hyperdynamic or normal?
Normal.
It looks like in the LVOT looks like it was almost cavity obliteration in systole.
Yep.
I bet it was hyperdynamic.
Let's see. I'll tell you. Give me 1 second. I think we have some numbers somewhere. Give me 1 second. I don't want to open it up there because I think that the screenshot has patient information. But let me see if I can get it to you here.
That's a good suggestion, Karen.
So the ejection fraction was 56%.
56.
Yeah, and the end systolic volume was 110. When you index that, it was only 37 milliliters per square meter, so not really that small for obliteration.
Yeah.
I mean, again, it's still in the differential. We'll see what the PET shows, and the PET might rule in sarcoid.
Sounds great. Thanks for sharing.
No, thank you guys for your. I'll keep you guys posted. Next month, hopefully, we'll have an answer on this one. All right, it's 5 p.m. I had a couple cases, but I think we're gonna save them for next month. I want to thank everyone that showed up and presented cases and showed up and just participated. We had a very nice showing today. Really appreciate all of you guys being here, and make sure to spread the word and let everybody knows that we're doing these get-togethers, and keep growing the group. Thank you all. Have a fantastic rest of your week.
Thank you, Jacoba. Thank you for keeping it up and running, bringing it to the 13th event, which is great. And the 13th event turned out to be actually very fortunate and not unfortunate.
Well, it was a bar mitzvah, we said, right? It was a bar mitzvah.
Yeah.
All right.
Wonderful. Thank you. Thank you,
Thank
everybody.
you.
Thank you.
Thank you, Jacobo.
Bye, Kiana.
Bye.
Bye.
Bye, Karen. Bye, everybody.